Okay, hypoxia in mechanically ventilated patients. Whenever you called about hypoxia in such patients, the first thing in whether they are intubated or not is to increase FiO2 to 100% to the maximum first, because the goal is to bring autosat above 90% as soon as possible. Remember this, hypoxia is an emergency, which means its life-threatening conditions need to be fixed as soon as possible. So the first thing I do when I get called about a patient with this, whether on the floor, intubated in ICU or not intubated, is I increase the FiO2 to 100%. This is easy on the ventilator. That's the first thing I do, because the goal now is to save the patient life. So you need to bring the autosat above 90% as soon as possible. If the patient is rapidly desaturating, I'm looking at the monitor and autosat is like going from 90s, 80s, 60s. There is no time, you need to intervene immediately. What we do, the first thing, disconnect from the ventilator, making sure, because we don't have time to check if the ventilator is functioning or not. And then we use ambu bag. We connect the patient ET tube to ambu bag. We started bagging him with the maximum O2 flow. Try to bring his autosat again above 90%. And once we bring it up there, we can reconnect him to the ventilator and then try to check what's going on. If the patient is fighting the ventilator, that means he or she is in desynchrony. The fastest way is to increase sedation or paralyzing the patient. That can fix the issue and give us some time to fix why the desynchrony happened and fix it. And again, these are temporizing measures. You need to get patients off paralytics as soon as possible, and you need to get rid of deep sedation as soon as possible. The fourth thing is increase recruitment and decrease de-recruitment whenever applicable. Again, this mainly in ARDS. Remember the prone ventilation, the very high increase in PEEP transiently, and treating the underlying cause can help with the recruitment. Decreasing de-recruitment is by increasing PEEP. And it's a common practice that when we want to increase O2 sat or PO2, either we go on the FiO2 or increase the PEEP. And actually the PEEP, sometimes we use it, we increase the PEEP to decrease the required FiO2 to decrease oxygen toxicity, which I'll talk about FiO2 and PEEP in the next video as well. So these are the issue. Again, the PEEP, I can use it if I make sure the patient is not fighting the vent. I did to 100% and the patient is still less than 90%, I may increase the PEEP. Or if I want to decrease the FiO2 requirement, but the PEEP decrease the recruitment and help with oxygenation. And most importantly, please do not forget to treat the underlying problem: pulmonary edema, pneumonia, PE, whatever causing the hypoxia. But remember, hypoxia is an emergency, needs as soon as possible treatment. You need to fix it, because simply the patient can quickly go into cardiac arrest if you don't treat it.